So hello everyone and welcome to the first KINterns virtual shadowing session. So KINterns is a program that aims to connect allied health professionals for students interested in a career in allied health. So like physiotherapy, athletic therapy, occupational therapy, all those kind of things. Today our presenter is Sharon Farquharson. She's a physiotherapist and she specializes in head, neck, and jaw. So she's actually a cervical and temporomandibular therapist. Sharon currently works at Headworks Physio in Burnaby. I'll put her website in the chat later in case you guys want to take a look. During the presentation, if you guys have any questions, just message in the chat. I'll monitor it while she's doing her presentation, and also at the end, there will be a Q&A. So thanks for coming, everyone, and then I think she's going to start her presentation now, so if you want to share your screen.
Yeah, okay, I'm gonna put it on full screen here. There we go. Good morning, everybody. Thank you for this opportunity to present a case study at KINterns. I'm going to be presenting a case study of a neck injury. But before I start, I'm going to talk a little bit about myself and my journey and how I got from there to here. Okay, so growing up, I always knew that I was going to be something in healthcare. So, because my mom was a nurse and, you know, my grandpa was a dentist. And so I thought, well, something in healthcare would be kind of neat because it would kind of be familiar. So growing up in Singapore, there wasn't a physio school and everybody grew up to be doctors and lawyers and engineers and accountants. So physio was kind of foreign. So in grade 2, when the teacher went around asking all the kids, oh, you know, what are you going to be when you grow up? Everybody went doctor, lawyer, engineer, accountant. So I just said, yeah, doctor. So there was that in the back burner until I became a teenager, about 15. One of my aunts, quite a close aunt of mine, she got a stroke and was quite unusual because she was in her mid-30s and it was quite unusual for her to be so young and have a stroke. Anyway, she was in rehab and there were physiotherapists in Singapore. They just had to do their schooling abroad. So I watched her go through rehab and I thought to myself, whoa, this is kind of a fun job. You know, you're not sitting at the desk and being bored and you're active. So I was inspired by that and wanted to be a physio. So after high school, because it was different back then in those days, it was an undergrad program. I picked New Zealand to go to because it was closer to home. And the cost was quite reasonable at that time. And I thought the weather was a bit better than where my sister went in Winnipeg. So there we are, New Zealand. Here I come. So what I do now, I'm a physio. I work at Headworks Physiotherapy. We do mostly car accidents. So there's a lot of head, neck injuries. And in my journey, I decided to become a bit more specialized and a bit more intentional with my career. So I did the certification exam and became a CCTT, so a Certified Cervical and Temporomandibular Therapist. And I was told that there are only 8 of these in Canada, so and 3 of them are in Vancouver. So, little definition of physical therapy or physiotherapy. In America, they call it physical therapy, and the rest of the world calls it physiotherapy. So, according to Oxford English Dictionary, so definition for you. So we don't do drugs, and we don't believe in surgery. Just stop it. All right. So let's move on to begin our case study here. I'm not sure if you guys are familiar with this examination. It's quite a universal method. We call it the SOAP. So for subjective, objective, assessment, and plan. Okay, so history is under subjective. So we start asking the patient. So at the time, the patient is a 23-year-old female. She is in pretty good general health. She doesn't take any meds usually, except for the occasional vitamins, supplements. No illnesses, so no kind of conditions like high blood pressure or diabetes or anything like that. And she has no past injuries. She runs 3 to 4 times a week for about 40 minutes each time. So she's keeping herself healthy and, you know, good up there. Unfortunately, she has a desk job. So we have a saying that sitting is the new smoking. So, okay, she came to me 10 days post MBA, motor vehicle accident. She was stopped at a red light coming home from work, and she got rear-ended. And she said that she felt 2 hits. She couldn't be sure, but she thought she felt 2 hits. And she said she might have been looking in her rearview mirror when that happened. She didn't have pain immediately. And so she went home over the weekend, rested, and she went back to work on the Monday. So Monday to Wednesday, she worked full days. And the first half of Thursday, she started feeling some pain. So she went home. And she went to saw her doctor the next day, who described painkillers and physiotherapy, and also 2 weeks of work. So here we are. She is 10 days post-op, and she comes to see me in the clinic. And she's saying that she complaining of left side neck pain and upper traps pain mostly. It's what kind of pain it was an achy pain, feeling tired, and it's worse at the end of the day. And also complains that her neck was a little bit stiff. And when she was asked if she had any headaches, she said, well, not really a headache, but she gets once a day, she gets like a sharp shooting pain in her temple area. And it lasts for like a couple seconds and then it's gone. There's no dizziness, no numbness or tingling, and no pins and needles, no vision changes. So that tells us that she didn't really have a concussion. She didn't bang her head, and no nerve involvement. So I'm thinking, oh, this is a bit straightforward. So it's pretty straightforward. So on observation, so you have to realize that your observation actually starts when she's sitting in the waiting room. So you're looking at her and she's not aware she's being observed. So it's her natural sitting posture. So you call her in and she walks. So you're going to observe her gait too, and how she's walking, if she's holding any parts in a kind of like a protective posture, how she's holding her shoulders, how she's walking. And then we get her in the room and she's going to be sitting. And then that's where you start interviewing her and you're looking at her neck, head and neck posture, shoulder levels, any asymmetry. Then what she's showing on her face, if she's in a lot of pain, you can see it. And how she talks too, you can kind of tell. Okay, bony soft tissue contours. Most of this, you tell them to put a tank top on and take their shirt off, ideally, so you can actually see, you know, any changes in the bony soft tissue contours and the ischemia. So if there's any changes in color, paleness, and of course, she's sitting for a while, so she'll be reverting to kind of off guard, normal sitting posture. So you can see if she's slumped, forward head posture, that kind of thing. Okay, then we are going to start our exam. So you're going to get her to move. So I got her to move, and you have to keep in mind, this is her first accident, and when she went home, she was kind of afraid. So she didn't move at all. She was really scared to move. So when she came in, she was really stiff because she'd been resting for quite a while. And also with that desk job didn't help. So Karam is cervical active range of motion. We're just going to look at her flexion, extension, side flexion and rotation. So all the cardinal motions. If there's anything that pops out, then we do the combination movement. So extension and side flexion, extension, rotation, to see if it brings on more symptoms. Then we have resisted isometric movements. I'm sure you know how to do those. So I just usually say, hold your head still and don't let me move you. And isometric movements differentiate muscular and joint origins. So if you think about it, if you're holding the patient, they are not moving. So the joint's not moving, but you're testing the muscle. Hope that makes sense. Okay, so quick scan. Peripheral joints. Usually we, when we look at a joint, we look at the joint above as well as the joint below, ideally. So what we look at is, can you move your shoulders? Can you lift your arms up? And then I just do a quick, you know, how's your jaw feel? Does it click? If it clicks, then we say, has it always been clicking? Is it sore? Just a quick screen. So myotomes, dermatomes, quick, you know, cotton ball or pinprick thing. Functional assessment, I usually just do, oh, can you, you know, can you just look down, look into your hip pocket, put your hands behind your back. But some of this you can see already by, you know, when she's taking her shirt off. Then the next thing we'll do is reflexes. I don't dwell too much on that because if she doesn't have any nerve symptoms anyway, we can do a quick reflex thing, but I don't dwell too much on that. And then we have the special tests, so brachial plexus tension tests, where you just pinch the nerve bundle at the base of the neck, between the neck and the shoulder, and distraction, which is like a traction, and just carry on and do the Sperling's test, you know, this neck flexion and compression in that position, and the slump test. Then you get them to stand because you're going to change positions, and this is like a balance test. So testing for nerve involvement, upper motor neuron, myelopathy, that kind of thing. And part of the observation is you want to try not to move the patient around too much. So all this was done in sitting. Then we get them to stand. I'll get her to stand and test the rhomboid. Then I got her to lie down, and that's where we test passive movements. So when you test passive movements, you just have to be careful if you're testing the neck and you really want to support the head because you want the patient to relax. And passive movements also, you are differentiating between muscle and joint. So in this instance, passive movements, you are testing the joint because the muscle will be relaxed. So if there's any joint problems, it'll come out here. And also you are testing for end feel, what it feels like at the end of the movement, if there's any guarding, what she's doing. If she's preventing the movement actively, you can tell. Then I did the upper limb tension test. So I'm not sure if you're familiar with that upper limb tension test, so the median nerve, radial nerve, and ulnar nerve, and see if there's any kind of tingling sensation in the nerve distribution of those nerves. So what I found in my observation is that she had, let me just go back here, in the active movements, she had, she was, like I said, she was very afraid to move. She hadn't moved really naturally, normally since her accident. And but she was able to move. So I said, you know, show me what you can do. So she had pain at the end of flexion on the left side, pain on extension on the right side. And then when she pointed, it was around C5, C6 on the right side. And decreased right side flexion. So I would say halfway, and then decreased right rotation. And she complained of feeling tightness. So going to the passive movements, so went ahead and did the ligament shear test, testing the stability of the joints. So these are the ligaments that you can do in the cervical joints, mostly the OC C joints. Okay, so occipital and cranial 1 and cranial 2. I meant cervical 1 and cervical 2, sorry. So in supine, you can test joint play. So you do a side glide and anterior glide, posterior glide, traction, and the rotation of the occiput on C1, which is a bit of a ligament test too, and palpation. So in supine, you can palpate the sternocleidomastoid and scalenes. The SCM is usually a usual one to be injured in a whiplash and accident. And there was a bit of guarding and tenderness on palpation of the left SCM. Okay. So joint play in prone. So we turn the patient over, ask her to go on her tummy, and we're going to test PAs and PAs over the transverse processes. And I found that there was a bit of stiffness in the facet joint on the right side. So in extension, there was a bit of a restriction there. And palpation, so in prone, you can palpate the upper traps, mid traps, and the levator scap. Those are quite common in this kind of injuries. And there was some soreness in the left side, so left upper quadrant. So here we go to analysis, which is the A part of the SOAP. Analysis means, what do you think of all that? What did you find? What do you think is wrong with her, basically? So pretty obvious that she had a whiplash injury. So I'm going to talk a little bit about whiplash. So whiplash is usually kind of a function of inertia. So she was sitting at a red light, and and she was hit from behind. So the car moved, but her head didn't because of inertia. So it whipped back, or the car whipped forward, really. So she had the hyperextension injury, and then when the car stopped moving, her head was still continuing to move, so it moved forward. So you get the flexion injury. So point of note, if you're sitting in the car, try to rest your head on the headrest. At least you can avoid that hyperextension, that first one. So when you're driving and everything, just make sure your headrest is at the right height and support it. So this is the kind of a grading system for whiplash. So 0 means no whiplash, so no neck complaints. So you don't usually see these people in your clinic because why? So you see, usually you see the 1s, 2s, and 3s complaining of neck pain, can't move, or nerve, sometimes nerve signs. Number 4, you don't really see them until kind of a bit down the line because they would have like a fracture. So they'll be in hospital or, wearing a brace kind of thing. So you don't really see these people. Okay. So we're going to go through this differential diagnosis, but not in detail because I didn't really do a differential diagnosis given her history, because it was pretty obvious what caused her pain and dysfunction. But for note, it's not a thoracic outlet because she didn't have skin pallor, no coolness, well, like I said, it's pretty obvious what she got, and she might have a facet syndrome because of that facet restriction. Okay, I will give you the references later. So this came from the PABC Physio Association guidelines for treatment goals for whiplash. So it gives you a little timeline. So following the timelines, you can plan your treatment. A little one here. This is because she was 10 days post MVA, she kind of fell in the phase 2 of the treatment plan. And you can look at this in more detail later if you want. I can email you this sheet. So plan, what are you going to do? So treatment plan, we not sure if you heard of RICE, but now we are into MICE. So education, manual therapy, and exercise modalities if needed. So MICE is short for movement, ice compression, elevation, mostly movement for cervical, ice if it's acute, Compression elevation, not really that relevant in a cervical injury. So rest has been replaced by movement because the research has shown that movement helps with healing. So encouraging the patient to move, because what she did was she spent the weekend and half of the week being afraid to move. So not so good. Okay, so education, most of the work we do is, there's a lot of education, explaining what happened to you and why you're sore and what you must do to help yourself. Because we all say, oh, you're only here for, you know, an hour a week or an hour twice a week, but the rest of the time you're home. So you need to help yourself by doing exercises and just trying to go back to normal activities. Pain modulation, so teaching them how to kind of decrease their pain. And then there's muscle re-education. So in a lot of whiplash, there's the deep flexor muscles that are injured. So they kind of, I use the term, go out of commission, and then the SCMs, the superficial neck muscles, try to do the job. So then they get more pain because they're not made to be doing the job of the deep flexor muscles. So we go into a little muscle re-education. So teaching the deep flexor muscles how to work again. So the plan that we do, I usually do manual therapy, so stretching, mostly mobs, so mobilizing the joints, particularly the C5-6, to get it to move again, to restore movement in that joint. And stretching is quite important for if it's muscular. So we always tell them to do the exercises at home. So we can't just say, okay, do these exercises at home, but we need to be specific about exercises that we prescribe. So I usually say, okay, you know, the test that I showed you at the beginning of the visit, you know, the range of motion. So you're going to do this. So I actually do the movements with them, and it's actually a slow movement. So you're going to look up, you're going to look down, and you're going to come back to the middle. You always come back to the middle. Then you're going to turn your head to the side as much as you can, and then turn your head to the left, turn your head to the right, come back to the middle, and then tip your head ear down to your shoulder as much as you can, and then to the left, and then come back to the middle. And you're going to do this one round, I call this one round, every hour. Okay, but of course some of them are not going to do it every hour. So you're going to say minimum 3 times a day, but ideally every hour if you can. So hopefully they'll do that. And then the stretching, so I showed how to do the upper traps stretch. It's pretty straightforward. And the levator scap stretch, and also hourly. So, you know, take a break from your from your job, from your desk, and do these. And it's going to take maybe about a minute, 2 minutes max to do all this. So every 2 minutes, every hour. So for stretching, you are going to tell them to hold it, because there's no point just doing, and definitely no bouncing. So hold it for 15 to 20 seconds, just to let the muscles kind of stretch out. Because if you do a quick stretch, it's going to be the same as like a stretch reflex, and that's not what you want to do. And the most important, go out and walk. Okay, walking is good. You know, swing your arms and just walk normally, get some fresh air, and just take a good break. Okay. Some of the modalities that PTs use, we can use heat, ultrasound, TENS. I usually tend not to use any modalities in the first treatment, because I want to see what just the movement does. So the next visit, I can see if it helped, if she's still in a lot of pain, if the pain is decreasing, then I know what helped and what didn't. Because if I pile on all the modalities all at once, then you don't know what worked. So, oops, sorry, too fast. So I have, so subsequently, the second visit, when she came back, she was quite a bit better. She'd actually gone back to work despite her 2 weeks off. Her boss wanted her to back to work because it's kind of over Christmas and things were quiet, but the boss wanted somebody in. So she said she felt better. She's being careful with her sitting, not slumping. So a lot of the things that physios do, we do a lot of behavioral modification, which is a good word for sit up straight, no slumping, put your head back and make sure that your shoulders, your ears are in line with your shoulders, all the ergonomic kind of thing. So also, I want to say that you need to be careful what you say to your patients, because what you say has a big influence on the healing and the pain levels. Because if you look into pain signs, what you put in their brains has a lot to do with how their pain feels. So be careful, and you want to try be as positive as you can. And the doctors, they might come in and say, "Oh, my doctor says it's a permanent chronic injury," and you're going, "Oh boy, why did they say that?" Right? So you want to turn that into something positive, and you try and change their thinking. Even if you don't change their thinking, subconsciously you are changing something. So just beware of that. Okay. So she went on and felt really good, and I'm continuing to see her. She's because of her desk job, like I said, sitting is the new smoking. She continues to have some pain, but it's diminishing every time we see her. She gets better, and she's back to running, but not so much running as fast walking, because running is a bit too jarring for now. She's getting better range of motion. She can turn her head, she can do a shoulder check, no problem. Neck pain is minimal, except for maybe end of the day, she feels a little bit more sore, and she has some strategies that she can use to mitigate that. So what you want to send them home with is self-help skills, self-management. So what happens if you're sore and you're in between visits? What you can do, a lot of times I say, because it's myofascial, she's got a lot of myofascial pain. I say put heat on it, because muscles and fascia, they like heat. And then so put heat on and stretch and do the movements, stretch again, and try to avoid too much head down activities. And I always talk about sleep, because sleep and pain are very closely related. So then we go into sleep and caffeine intake and screen time kind of thing. So there's always use the 10-to-1 rule, if you've heard of it. So what it is the conventional wisdom says 10 hours before bedtime, no caffeine. Some of you are like, oh, no caffeine. Yeah, caffeine has a really long half-life, so it takes a really long time for all the caffeine to be eliminated from your system. So ideally 10 hours before bedtime, you want to cut out your caffeine. It's not so much the ability to fall asleep, it's more of what it does to your sleep cycles. It's kind of messes up your sleep cycles, and you don't get enough of that deep sleep. So deep sleep is the restorative sleep, which helps with healing. And then 2 hours before bedtime, no vigorous exercise, but I say stretching, walking, leisure walk is okay. But jumping on a trampoline or going for a jog or lifting weights, no, not 2 hours before bedtime. And 1 hour before bedtime, and a lot of the young people don't like me for that, but 1 hour before bedtime, no screens. So it's the blue light that messes up with your circadian rhythm and impedes melatonin production. So what I say is just read, just do your bedtime routine, make it calming, make your body kind of wind down and be ready for bed. So even if you can, look at your phone and 2 minutes before you go to bed, the light is gonna mess you up. So not the ability to fall asleep again, like the caffeine, but also messes up your sleep cycles. So 10-to-1 rule, which I always use when I talk to my patients about sleep hygiene. Make sure your room is dark, no sounds, no disturbances. Make sure your dog doesn't come in the middle of the night and wake you up. So disrupted sleep is not so good either. Okay, so here are my references. So the grading of the Whiplash is taken from the Quebec Task Force for WAD, which is Whiplash associated disorders. And then the PABC guideline, which I showed you. And if you want a copy of, I can send it to you. I'll send it to Leah anyway. And where did this come from? Oh, the mechanism in Whiplash. And then this text, if you, sorry, we talked about that. We talked about that. Coming back to this, let me go back to this again and see. So second visit or subsequent visits, we reviewed some symptoms, talk about her return to work, we said that already, and we review the exercises. So I say, well, show me what you've been doing. So a lot of them would have, if they've been doing them religiously, like you said, every hour, then they'll be able to show you correctly what they do for their stretching and for their movements. But a lot of times you will see that you have to do some corrections, because they will say, oh yeah, I've been doing my exercises and this is what I do, and then you find that no, not exactly, then you have to correct them. Okay, so reassessment also, and then treatment accordingly. So if they're still in a lot of pain, then I'll change my treatment, maybe apply some ultrasound, heat and ultrasound. I mean, even if it's ultrasound, if the study says it's placebo is still an effect. So, and a lot of them like the ultrasound, especially on muscles. So okay, and then send them home with some self-management. If she's ready for discharge, which is she is right on the cusp of being ready for discharge, we will I will send her back home with self-management skills. So what happens if she gets really sore and she can't come back, or she's too busy, what she can do. Her prognosis is pretty good because she's young. It's her first injury, and she doesn't have any pre-existing conditions, no pre-existing neck pain. But the downside is she has a desk job, so that's gonna kind of hurt her. So as long as she's aware of that and takes breaks, necessary breaks, and she's keeping herself active, so hopefully she will go back to running and keep up her activity level. That'll be good. So I don't see any long-term adverse effects for her, really. So this is my favorite reference for physical assessment. This is the newest edition. So Dave McGee, he's a Kiwi, he's New Zealander. And he goes through every part of the body and goes through how you do the exam, and has all the special tests and stability tests, and then also some case studies at the end of every chapter. So I found this to be a really good resource. So time for questions.
Okay, so you guys can either put your questions in the chat, or if you want to just ask it verbally, you can raise your hand. There's one question: how long do you usually have with a patient, and approximately how long does it take to go through each part of the SOAP process?
I would say, well, if you're in private clinic, you're kind of limited. So the first visit is usually 45 minutes. So it depends on the patient too. Some patients like to talk a lot. And if they talk a lot, then you kind of have to hurry through the SOAP process. If they don't talk as much, then you have to prod them and ask questions and, dig a little bit into the history. So 45 minutes is the kind of the total time I get. Some clinics have an hour, but for I also do TMD. So for TMD, I usually give an hour. So within that 45 minutes, they tell you their story. They you go through the SOAP, and then you have to kind of do a little treatment or send them home with something to do. So I hope that answers your question. I don't really say, oh, the subjective takes, it kind of flows into each other. Yeah. Sometimes something comes up in the objective and then you go back to asking the subjective. You know what I mean?
Yeah, so like it kind of depends on the patient and what you see with them.
Yeah.
So another question is, do you see a lot of chronic whiplash injuries and how do you go about that? So like, would you say most of your patients are chronic whiplash injuries?
Yeah, see, the problem is a lot of patients would be chronic. Whether or not that is real or not is not for me to judge. So for me, everybody's pain is real. You want to go in there thinking that everybody's pain is real, because pain, you want to look now at the catch term now is the biopsychosocial model of pain. So the biology of pain is, well, they had an injury, so yeah, they are in pain. Socially, what did they learn from the doctor, their friends, what they have people been telling them? And psychologically, what does pain mean to them? Growing up, even going back to their past, have they seen people in pain, and what does that mean to them? So all this builds up their pain psychosocial model. And pain is different for everybody. So some people can have a huge injury and no pain, and some people have a small injury and lots of pain. So it depends on how they perceive pain. So yeah, a lot of the people I see in that clinic in particular have a lot of chronic pain because they want to have passive treatment. And sometimes it's really hard to get them past that. You have to do the job yourself. You have to move, you have to exercise, and also you have to move in spite of pain. And a lot of people just don't want to. And I always say, I can't get you down to zero. It's just not possible. You have to sometimes you kind of have to live with the pain and accept it as part of your life and just keep going, because that's how you deal with chronic pain. Chronic pain is a different animal from acute pain. It's just different. So I don't know what else to say. Yeah, do a lot of chronic pain and they coming back, and you do a lot of education. I want to see nagging, but it's education. Just somehow you have to persuade them that they have to move.
Okay, another question is, can you give us more detail on your journey to physiotherapy school? And also, like, how long did it take you to complete your cervical and temporomandibular certifications?
So for me, and also back then, the physiotherapy degree was an undergrad degree, so it wasn't a master's. So we did 4 years of just purely physio. It was like a set program. You didn't have to pick your courses. It was like, if you're going to do physio, these are the courses you take. And it was it was just undergrad. What more about my journey? So in high school, I did all the sciences, so biology, chemistry, physics, which was necessary to get into physio school, which I think you found too. If you're in kin, that's what you needed. And yeah, that's how I did my physio school. And to do the CCTT, there were some prerequisites before you took the exam. You had to have 5 years of continuing ed, 100 hours, 5 years or 100 hours. Actually, it was 100 hours of continuing ed and 5 years of treating patients with neck and jaw pain. So you kind of have to, I would say, use the term apprentice with someone who's doing jaw stuff as well, so that you can get your hands on, some practice on jaw things, and you're familiar and you know what to do in a jaw thing. So you're actually treating jaws before you get your certification. Okay. So you have to have 5 years of that. Not 100%, but a good percentage of necks and jaws. And self-study. So you have to show continuing education targeted towards neck and jaw. And then you take the exam. So what it is the exam is held by a group called the Physiotherapy Board of Cranial and Cervical Therapeutics. So this is an organization in the States, and they are part of the AAOP, which is the American Academy of Orofacial Pain. And they have meetings every year. I want to say every year, but not last year and not this year because of, coronavirus. And they hold them all over the United States. So some years they'll be in like Florida, sometimes they'll be in Denver, and it's kind of like a 4-day conference. So you have to make the commitment that you're going to travel down there and attend the conference. So that counts towards your continuing ed as well. And so there'll be like the first day would be a PT session for PTs who are doing this conference, and it'll be like it'll be like one of these courses that you go to. So it's a whole day hands-on. Some PT would present something to do with neck or jaw, and then you would do like a practice session. And then the remainder of the days will be plenary sessions, lectures, and research. So people will be presenting their research, or people who have written papers, all the professors and top-notch jaw and orofacial pain specialists. Now it's a specialty in the United States, would present and talk about, central sensitization, which is a big thing for orofacial pain. And so you attend that for, I would say, you need to attend that for 5 years before you apply to sit for the exam. And then there's a lot of self-study for the exam. There's no, there's no past year exam questions that you can practice on. So you basically have to know everything because you don't know what's going to come up in the exam. So, but it's a multi-choice exam, 3 hours. And you have to travel down to wherever that conference is happening that year. You go to do the exam before the conference. So that's what I did, and did my exam. And then I say 6 to 8 weeks later, you get the email saying, congratulations, or we regret to inform you, kind of thing. So yeah, that's what happened.
Okay. Sounds very cool. There's another question in the chat about the importance of like sleep and specifically sleeping position. So like if you have a cervical injury, would you recommend a certain sleeping position, or like does it not matter?
Sleeping position. Well, I'm not too hung up on sleeping positions when it comes to my patients, but the one certain sleeping position we want to really avoid is the tummy sleeping. Okay, definitely no tummy sleeping, because if you sleep in a tummy, just imagine what your neck has to do for you to breathe. You have to crank your neck all the way around, and then you're putting pressure on it all night. It's really hard on the neck. I mean, even for somebody who has no neck pain, you're going to end up with neck pain eventually. So the best sleeping position, the research says, is on your back. So on your back, and then just a little support for your neck. But some people can't sleep on their backs. And sleep is, for me, I think sleep is really hard to change. If you're used to sleeping on your side, you're going to have restless nights sleeping on your back. So you can change them gradually. If they're keen, you can say just, prop pillows around your hips, or roll a towel and prop it on your hips on the front and back, and slowly change your position. You can't change it in one night. If you sleeping on his side, I would say have enough support to bridge the gap between your ear and the end of your shoulder. So not too much and not too little, because your neck is you want to keep your neck straight. That's what it is.
Okay, another question is, what does a typical week look like for a physiotherapist, and do you do work like outside of any work hours? I feel like
that's a good question. That's always the bane. Yeah. Okay. So right now, the beauty about physiotherapy is you can work part-time. So if you have, if you have a family, and you can pick your hours. depending on your clinic too and your boss, but can be quite flexible. So right now I'm working in the clinic 2 days, Monday and Wednesday, which are actually quite long days. I work, I say, what, 9:30 on Mondays. I work 9:30 to about 7:30, and then on Wednesdays, because I want to catch the early morning before work people, I start at 8 and I go to about 6 or 7. So after work people too. And I had to give up my Thursdays because I used to go to work on Thursdays for half a day, but because of coronavirus, they only wanted 2 physios at a time in the clinic. So give up my Thursdays, but Thursdays have been tele rehab. So we go online and we visit with the patient, go through the exercises mostly, see how they're doing, and if there's any more modifications you can do, any new exercises, anything new happened to them, or any new injury or anything they found. And another thing that I do is orofacial myofunctional therapy, and that is a good thing to do online. So as long as the first visit is in person, you can do the rest of that pretty much online. And then of course, if you don't chart in between your patients, then you have all the charting to catch up with. And you'll always hear this complaint that I hate charting, So yeah.
All right. Do you think it was easy to transfer your physio credentials from New Zealand to Canada?
That's a good question. Yeah, that was a good question. I was how do you say? I was very fortunate that I was able to just transfer over without sitting the exam, but that was a number of years ago, and things are different now. So if you are going to go abroad for your PT, then be prepared to sit the exam. So I think part of the exam is you have to work as an interim physio first. So you have to find a clinic that will take you as an interim physio. And then during that, you will get hopefully some mentoring from the physios there. But then you have to do some self-studying. I would say the sooner you take the PNE, the Physio National Exam, the better, because then you have all your facts, have all your knowledge fresh.
How do your patients react when they come to know that their injury cannot be healed? What do you say to them, and do you prescribe anything special, like any certain exercises or pain modalities?
I never say that. I never say to them that the injury cannot be healed, because that's one of the things that you build into their psyche is not a good thing. So never say that they have a chronic condition. Never say that they have something that cannot be healed, because what you do with a chronic condition is you are not changing the condition, you are actually changing the brain. Because in chronic conditions, most of the time, the physical aspect, they're actually healed. Physically, there's nothing wrong with them, okay? But the brain is still making pain because of all that other input from the subconscious parts. So it's not to say that the pain is, they're faking it, they're not, because the brain is still making pain. So you are actually trying to educate that part of the brain. So like I said, chronic pain is a different animal. You're not dealing with the injury anymore. So if you keep saying that, you can't be healed, then you're just going to compound that, and it's going to turn into a self-fulfilling. They're going to have pain for the rest of their lives. So there's a lot of pain education that needs to go on with that. So a little education in pain science is not going to hurt you in your, your continuing ed, or if you want to go into that as a specialty, that would be, pain science would be useful to use for people who are in chronic pain.
Do you want to talk a bit about how you go out and get clients, like promoting yourself?
Okay, because I'm in a clinic, right now I don't have to do a lot of promoting. ICBC, there's a lot of ICBC cases, and then people go to their doctors and they say, oh, go see a physio. And there's a lot of repeat clients. So people who have come to us before, maybe for a private injury. Now that they have a car accident, they come back. And then for the CCTT part, you being a CCT, you are included in the directory. So the association will do the marketing for you. And then if there's dentists around, I used to talk to the dentist as well. I would give, I don't do that very much anymore, but maybe because it's because of coronavirus, I would do attend dental study groups. You find that, well, for me, it's a bit different because I would talk to dentists more than, I get referrals more from dentists than from doctors. As part of the being the jaw specialist. So I'll talk to dentists, attend the study groups, and I would give a little talk on, you know, TMD and PT, because for the most part, somebody with TMD would go to the dentist first, usually, because it's, you know, it's jaw pain, teeth, you know, they think it's the tooth is aching or something like that. So then the dentist would send them to me or to the other two people in Vancouver. Also, what I've been doing too is I've been sending out a marketing thing. So every year I would send them like maybe a calendar with you know, the Headworks logo. Send to referring dentists, I would send maybe chocolates and thank you for your referral, kind of thing. And stuff that the clinic should do for the doctors, really. And that will draw clients to your clinic. And also what I do is part of the treatment, I would write a report within 1 or 2 months of seeing the patient. I would see the patient at least twice before I do the report. So I do just a quick 2-page report, brief history and findings and recommendations. And then, you know, of course, the preamble, thank you for referral. If they didn't refer you, take the name of the patient, the doctor or the dentist, and say, I saw so-and-so in our clinic. And then CC the other professionals involved so they know, just put your name out there.
All right, would there be any jobs that you recommend before starting physiotherapy?
Maybe some volunteer jobs. I don't know what the case is now for coronavirus. I know somebody who is going to school for OT, and she's actually working in an OT, not an OT clinic, but in an OT setting. So she's doing the, you know, the assistant part, and she's actually working. So you could do like a physio assistant job. I'm not sure how many of them there are out there. It probably have to be a bigger clinic to be able to afford that, because I don't think you would be able to bill for that, so they'll have to pay out of their clinic expenses. Yeah. So working as a physio assistant or volunteering would be good jobs, or any kind of hospital setting or any clinic setting would be good.
How did you go about like doing your apprenticeship? So when you're practicing your TMJ or head and neck stuff before you got your certificate, like how did you go about being an apprentice?
Okay, I have to say that I kind of fell into it by accident. So I was on mat leave after my third kid, and sort of saw this ad on PABC, and I thought, oh, she said that I was going to do a locum, and it would have to involve some training in TMD. So I thought that was interesting, and so I went, and it was one of the CCTTs. But back then she was preparing to sit her exam, so she taught me a few basics, and that was how I got started. I was just kind of pretty much thrown in. I did the locum for 9 months, and then I couldn't continue anymore. It didn't really need me anymore, and then by then I was working on kid number 4, and then when I went back to work after kid number 4, actually kid number 5 actually, so worked kind of really part-time between those two, 4 and 5. And then after kid 5, I actually did a bit of school physio. And then after school physio, I was still thinking about this TMJ physio, and I had it on the back of my mind, but kind of decided to be more intentional and pursue that. And that's how I kind of did the self-study, started attending the conferences, and yeah, pretty much went back to private practice and started working on jaws and necks.
Okay, so this is just going to be the last question. Do you want to compare like your working in the clinic versus working like holding your own clinic? So having your own clinic versus working for a clinic.
Okay, it depends on where you are in your life. If you're young and have lots of energy, you would want to own your own clinic. But I will tell you that owning your own clinic is, I think it's a lot of work, because you have to do all the business stuff as well, and you have to look after the equipment. If any equipment fails, you are the one who's going to be ringing up the supplier or the the repair person. If a physio falls sick, you're going to be the replacement. And in the beginning, if you don't have a receptionist, you are going to be it. So there's a lot of behind the scenes stuff that you'll be happy to pay a percentage of your billings to have taken care of. I think eventually, depending on where you are. I mean, for somebody who wants to work part-time, I would say, yeah, just work for a clinic and they can take care of all the overheads, because you have to remember you also have to pay rent. And that's and usually it's a lease and it's a contract. So are you sure you're going to have the patient load to be able to enable you to pay rent? So, but do your market research as well. I mean, if you're in an area that needs a physio clinic, it might be worth doing. So I don't want to deal with all the logistics and the behind the scenes stuff. I just want to be a physio. So that's why I'm working in a clinic, for a clinic.
All right, guys. So that concludes the first KINterns virtual shadowing session. I put the quiz link in the chat, so you guys can just fill that out for participation. And I'll probably send like the certificates of participation hopefully within the week. If you guys have any more questions or your question wasn't answered, I'll make a Q&A section on the group chat, so you guys can ask your questions there, and I can help ask Mrs. Farquharson about it. Yeah, so thanks everyone for coming, and see you guys on March 6th.
Thank you.